Hi, my name is Jill Wars, and I'm presenting Improving Care of Pediatric Patients with Bronchiolitis. My committee members include my chair, Dr. Heather Deering, my second reader, Dr. Wunderlich. The community members include Julie Dale, our advanced practice lead, Dr. Paul Hansen, our chair for clinical quality. Bronchiolitis is a common respiratory infection, particularly in children under 2 years old. It occurs from the winter to spring months. It's a leading cause of pediatric visits to urgent care. Symptoms can range from a runny nose to mild cough, fevers, moderate to severe cough, retractions, wheezing, and sometimes dehydration. It is essential that providers working in urgent care efficiently triage and effectively treat these pediatric patients according to the guideline recommendations. The purpose of this project was to implement evidence-based bronchiolitis clinical practice guidelines, to decrease chest x-rays, antibiotics, and steroids ordered by providers within urgent care when caring for pediatric patients aged 6 to 18 months with bronchiolitis by the end of the project's intervention season in 2024. Secondary aims include standardization of practice, improved resource utilization, and improved parent and caregiver education. After reviewing the literature, educational interventions and performance feedback helped improve care in the following ways. The providers were encouraged to follow a more concise algorithm, including a severity scale. CPGs, including the algorithm, were embedded into the EMR for easier access by the frontline providers, and patient risk factors for identifying those patients with moderate to higher risk for deterioration were outlined. Reliability was established throughout the articles as they demonstrated that implementing similar interventions improved provider adherence to guidelines. The interventions that were implemented within the studies reviewed are generalizable to the pediatric population within the urgent care settings, small and large. Weaknesses included time restraints were as bronchiolitis is seasonal. Interventions were not tailored to specific levels of care, which makes the results reported less reliable. Gaps in the literature include minimal discussion on proactive interventions that would enable providers to provide supportive care and anticipatory guidance for the caregivers and family members, and promote access to follow-up across the health continuum. The theoretical framework that was used for my project includes the Rosworm and Larrabee model for change. The theory uses a systematic approach and includes all team members, administration, and stakeholders. It affected the formation of the work as follows. This quality improvement project first assessed what needed to change in the current practice setting. Step 2 was correlating the identified practice change that was needed with the initiative and the prospective outcome. Step 3, critiquing the research. After critiquing, I decided that the intervention would consist of education, improved access to the current bronchiolitis clinical practice guidelines as per the American Academy of Pediatrics, and developing a template for providers to use. Step 5, implementation and evaluation occurred via email communications, and the last step was integrating and maintaining the change. The method and design. The DNP scholarly project was conducted at an urgent care center located in the Midwest region of the United States. The sample included pediatric patients 6 to 18 months treated for bronchiolitis in the pre and post intervention seasons. The focus of this study was to determine if providing focused interventions would improve provider compliance with bronchiolitis CPGs, thereby reducing chest x-rays, steroids, and antibiotics. Prior to this quality improvement project, no consistent education was provided to the providers regarding adherence to bronchiolitis CPGs and strategies to avoid unnecessary testing and treatments. The author implemented a QI program in collaboration with the Special Counsel Lead, APL, and the providers working within the urgent care. The following strategies were implemented. Number 1, education was offered to the providers that included a comprehensive review of the bronchiolitis CPGs. Number 2, the bronchiolitis CPG was embedded into the EMR. And number 3, providers were provided a template for use for clinical documentation. The goal was to improve compliance and overall quality of bronchiolitis care. Clinical practice guidelines are intended to guide the provider's decision-making. They are evidence-based recommendations that balance benefit versus harm. When the evidence quality is rated as A, the intervention is well-designed and supported by conducted trials involving meta-analysis on the applicable population. Level B indicates that the evidence quality is supported by studies with minor limitations, however consistent findings from multiple observational studies. These levels have strong recommendations that the benefit predominates over the risk. So you can see on this bronchiolitis recommendations, the avoidance of chest x-rays is a category B with strong recommendations. It is recommended that the provider obtain a good history of the present illness, consider increased risk factors, and perform a thorough exam. Avoidance of systemic steroids is category A with strong recommendations. Studies have shown that steroids do not significantly reduce the duration of illness or lessen the potential for worsening symptoms that would necessitate an ER visit. Excuse me. The avoidance of antibiotics is a category B with strong recommendations. Bronchiolitis is viral in nature and antibiotics do not treat viruses. The provider should assess for secondary bacterial infections such as an ear infection, bacterial pneumonia, or a urinary tract infection and prescribe antibiotics at their discretion. Antibiotic stewardship is essential as overuse can contribute to the development of drug-resistant bacteria. We need these antibiotics to be effective when they are truly needed. This is a bronchiolitis CPG that was embedded into the EMR for improved accessibility and use. As depicted in this algorithm, chest x-rays, oral steroids, and antibiotics are not recommended for use. Obviously, the provider assessing the patient in clinic will use their clinical judgment to escalate care and provide interventions as they determine are needed. Here's the template that I created and shared with the providers to make documentation more concise. It pulls in the chief complaints, meds, allergies, history. The user can F2 through the necessary documentation and change details as needed. The respiratory clinical score is a tool used to assess the severity of respiratory distress, which informs clinical decisions. The plan, which informs the parent of supportive care and teaches them about retractions, can be copied and pasted into the wrap-up or education and either printed or sent to the My Mercy portal. Sample. The design for this QI project included quantitative data, inclusion criteria that was included 6 to 18 months age with a diagnosis of bronchiolitis or URI, upper respiratory illness, treated in urgent care between September 1st through November 30th, 2023 pre-intervention, and September 1st through November 30th, 2024 for post-intervention. And lastly, the documentation needed to have included whether the patient received a chest x-ray, antibiotics, or steroids. These inclusion criteria were entered into the slicer-dicer tool that is built into the EMR. Utilizing the slicer-dicer tool, nominal data was collected regarding the frequency of chest x-rays, antibiotics, and steroids ordered for pediatric patients 6 to 18 months treated for bronchiolitis and URI in urgent care pre- and post-intervention. Analysis was conducted using a directional chi-square test with an effect size of 0.05 to assess the differences in treatment frequency pre- and post-intervention. Additionally, a lower z-tail test for the difference of two proportions was used to determine if there was a statistically significant difference between the frequency of chest x-rays, antibiotics, and steroids ordered 2023 pre-intervention and 2024 post-intervention. These tests were recommended after collaboration with Maryville University's statistician Mark Pauls. A total of 11 patients pre-intervention and 15 patients post-intervention were included in the study. In 2023, 1 steroid, 3 antibiotics, and no chest x-rays were ordered for the 11 patients. In 2024, no steroids, 5 antibiotics, and 4 chest x-rays were ordered for the 15 patients. As depicted on this graph, fewer steroids were utilized in 2024. However, more antibiotics and chest x-rays were utilized. For this study, the lower tail z-test for the difference of two proportions were utilized. Basically, the post-intervention group had statistically higher rates for chest x-rays than the pre-intervention group. Regarding antibiotics, the post-intervention group had statistically higher rates of antibiotics than the pre-intervention group. Finally, regarding steroids, the post-intervention group had statistically lower rates of steroids than the pre-intervention group. The study results indicated that a larger sample size was needed as the results were not statistically significant. Limitations. Reasons for the differences between the observed and expected outcomes included a short implementation period, small sample size, resistance on behalf of the providers to change, and the lack of adequate monitoring and feedback for providers. Another limitation was the slicer-dicer tool, as this built-in tool allows a general search criteria for de-identified patient data, leading to the question of missing or incomplete data within the patient's records. Logistical constraints exist when using the slicer-dicer tool, as it provides objective data based on the specified search criteria. The author was unable to evaluate provider practices, thereby inhibiting the ability to provide real-time feedback to specific providers. Access to metrics such as steroids and antibiotic stewardship amongst the staff would help to gauge the need for additional education and development of educational resources to facilitate adherence. The study did not explore other external influences on providers' behavior, including staffing levels, organizational culture, staff burnout, or the prevalence of secondary bacterial infections in pediatric patients with bronchiolitis, including acute otitis media. Strategies to improve outcomes in the future include a more robust educational program, a dashboard for monitoring progress that would allow real-time feedback, a 6-month time frame versus 3 months, a more labor-intensive retrospective chart review that does not include the slicer-dicer tool to allow a more concise process for data collection and analysis. Discussion. The results of the study imply that the educational intervention that focused on improving adherence to bronchiolitis CPGs did not prove to be statistically significant in reducing the proportion of chest x-rays, antibiotics, and steroids that were ordered for pediatric patients treated in urgent care versus pre-intervention. Reasons for the differences between the observed and expected outcomes included a short implementation period, small sample size, provider resistance, a lack of monitoring and feedback for providers. Identifying these barriers provides an important understanding that informs QI initiatives in the future that aim to improve the quality of care through educational interventions that enhance adherence to guidelines. Implications for practice. This DNP project highlighted and informed the providers of existing evidence-based clinical practice guidelines and the importance of adherence. The project promoted a reduction in the use of low-value, costly interventions and also encouraged antibiotic and steroid stewardship. The educational intervention provided was informative and comprehensive in informing providers of recommendations, enablers and barriers to adherence, education for parents, resources for continued care across the health system, accessibility of tools, and the goals of the QI project. Tools such as the slicer-dicer tool for data analysis, the embedded CPG, and the provided template help inform providers that these tools are readily accessible, not just for management. This project has taught me to be more aware of clinical practice guidelines, the importance of adherence, aware of the tools within the EMR, and as a provider working in clinic, I can promote quality initiatives to help improve the overall care quality that is being provided to urgent care patients. In summary, working as a nurse practitioner in urgent care, when I see a small child who is experiencing mild to moderate respiratory distress, the urge to perform a chest X-ray to rule out pneumonia, provide a steroid, or prescribe antibiotics just in case is strong. By providing solid evidence-based recommendations as put forth by the American Academy of Pediatrics, education on the importance of adherence, and tools that support decision-making and documentation, I felt empowered and as if I made a difference, even if the findings were not found to be statistically significant. I feel that my QI initiative was well received by my fellow providers, committee members, and management team. I believe that my DNP project created a platform for continued educational intervention in support of adherence to clinical practice guidelines and protocols, applicable not only to urgent care, but also to emergency departments and inpatient care settings. Moving forward, the educational intervention does need to be more robust and ongoing, include real-time evaluations of provider performance with back and forth communication and more discussion on barriers and the ways in which to overcome these. Throughout this DNP program, I gained a deeper understanding of evidence-based practice and systems thinking. I feel more confident as a clinical leader. Throughout the last 2 years, I have felt overwhelmed, humbled, and inspired. I am grateful for the opportunity afforded to me as a DNP almost graduate. Thank you for listening to my presentation on improving the care of pediatric patients with bronchiolitis. And here are my references.